Hello everyone, welcome to Hospital Medicine Essentials on Sepsis presented by the IM Chiefs. To begin, what is sepsis? Well, if you use the Harrison textbook definition, sepsis is a threat to life caused by organ dysfunction, caused by dysregulated immune response, caused by infection. If you think that that is nebulous and difficult to pin down, you are correct. Welcome to sepsis. We've made several attempts to really formally define this over the years, the first of which is called Sepsis 1 from the early 1990s. It uses something called SIRS criteria. So to meet this definition of sepsis, you need a source of infection plus greater than or equal to 2 of temperature greater than 38 or less than 36, heart rate greater than 90, respiratory rate greater than 20, white cell count greater than 12,000 or less than 4,000, or bands greater than 10%. And then the respiratory rate has this PaCO2, but that doesn't get used very often. Sepsis 2 was an update in the early 2000s, still based on SIRS, but with some additional details. Sepsis 3 is from 2016, is the most recent, and it uses something called the Sequential Assessment of Organ Failure, a broader tool which measures organ failure in 6 different systems and gives each system a score from 0 to 4 points, with 0 being working properly and 4 being completely failed. Sepsis then is an increase greater than or equal to 2 in your SOFA score. Septic shock is sepsis plus lactic acid greater than 2 in the serum plus pressors for mean arterial pressure maintenance greater than or equal to 65 millimeters of mercury. This is kind of cumbersome. It's difficult to memorize. It's difficult to use at the bedside. It's not very practical. So they also created Quick SOFA or Q SOFA, for which you need greater than or equal to 2 of respiratory rate greater than 22, altered mental status with GCS less than 15, systolic blood pressure less than 100, less than or equal to 100, and that's it. However, these don't get used. Part of that has to do with how sepsis is billed, and part of that has to do with the fact that later studies showed that Q-SOFA, as the only tool for assessing whether sepsis was present, was less sensitive than SIRS criteria and a few other criteria systems that have been used throughout the years. So this may show up in your UWorld but doesn't get used. What really gets used at CHI centers is SIRS criteria. Sepsis is SIRS plus infection, so pneumonia, UTI, something like that. Severe sepsis is sepsis plus organ dysfunction, whether that's a kidney injury, LFT elevation, hypoxia, and so on. And septic shock is severe sepsis plus hypotension, which is not responsive to fluid resuscitation. That is how you should document sepsis for our purposes. When it comes to the management of sepsis, within an hour of sepsis being diagnosed, you want to measure the lactate. You want to get blood cultures before antibiotics. You want to give those broad-spectrum antibiotics, give a fluid bolus if necessary, and then apply vasopressors if that still does not resolve hypotension. For most patients, vancomycin are going to be the right antibiotics. You can use cefepime or meropenem in the Zosyn spot, but beware that cefepime does not cover for anaerobes, so that needs to be accounted for if you choose to use cefepime. If the patient is neutropenic, the absolute neutrophil count less than 500, you give one of the same for monotherapy. Add vancomycin if the patient has one of these risk factors for MRSA. And if the patient has had a splenectomy, then you want to reach for ceftriaxone. For fluids, lactated Ringer's is the best. You technically can use normal saline. Crystalloid is okay, so normal saline does work. But patients in sepsis are typically going to develop some amount of lactic acidosis, depending on how severe it is. Normal saline, as you all probably know, can cause non-anion gap metabolic acidosis, and so combining an acidosis with an acidosis is bad, so just use lactated Ringer's. If you're not going to give this full bolus when it's indicated, you need to document why you didn't give it. If you do need vasopressors, and remember that magic number for mean arterial pressure is 65 millimeters of mercury, then you reach for norepinephrine first, and you can kind of go down the list. Those patients will probably end up in the ICU, so you don't need to worry too much about that. Supportive therapy, you want glucose between 140 and 180. If it's higher than 180, it's harder to get rid of the infection, but if it's lower than 140, aggressive glucose control has been shown to increase the risk of hypoglycemic events. You need DVT prophylaxis, you need a PPI because a stress ulcer is very common in critically ill patients. You want to minimize their sedation as much as possible, and you want to be quick to reach for renal replacement therapy. Here are our references. I will link the SOFA MD Calc in the description. I hope this was helpful.